Well, thank you very much indeed to Jean Hales for Women's Health for their leadership and for inviting me to speak and to participate, and to the Australian Government for their vision in sponsoring this event. So those of us who work in women's health will be pretty familiar with the question of why women's health? Why aren't you interested in the health of everyone, the health of the population at large? And women's health is really the field that is specifically focused on conditions that are specific to women or are more prevalent among women. And the two that are best known in this area are maternal, sexual and reproductive health, one of the focuses of our work in the next 2 days, and of mental health, where women experience a disproportionate burden in particular of non-psychotic mental health problems. But it's also important to think about women's health in relation to the specific risk and protective factors that might pertain to different groups in the community, including women and men, where symptoms might not be the same, where responses to treatments might not be the same, and where there are inequalities related to gender in terms of access, availability and affordability of services, and the need for well-informed health education and health promotion. I wanted to take you back. David's talked about a recent community of interest, but in fact this community of interest is of long standing in Australia. And I want to honour people like Gwen Gray, who were pioneers of this movement a long time ago. The idea for a national women's health policy was first resolved at the 1985 Second National Conference on Women's Health, held in Adelaide. And they determined that the policy should be focused on an understanding of the social view of health and the recognition that the health of the whole population of women was important, and it should be a whole of government concern. So very visionary ideas. And in 1989, testament, I think, to the effects of their advocacy, Prime Minister Bob Hawke and then Health Minister Dr Neil Blewett launched our first national women's health policy. And among the 7 priorities identified then, 4 continue to represent significant challenges. In my opinion, the other 3 of occupational health, women's unpaid work as carers, and the impact of sex role stereotyping continue to be important but are no longer identified as priorities. It took a very long time for us first to have a national Aboriginal and Torres Strait Islander women's health policy, and it was launched at a conference of the Australian Women's Health Network in Hobart in 2010. And while I want to recognise the work of Kelly Bannister and Lorraine Greaves, leaders in this field, I think you'll see in the background that some of us have been doing this for a long time. I also think that Marilyn Beaumont, I wish she was in this image. It's wonderful that she's here, but she was one of the conveners of this very important conference. It was followed quite soon by the 2010 update of the National Women's Health Policy, which drew on the first one, but really pointed out that the way in which society is structured is of fundamental importance to women's health and well-being, and that we have to focus on prevention, that this should be a priority, and that any reduction in health inequalities requires much broader reforms that attend to these social inequalities. It occurred almost at the same time as the launch of WHO's Commission on the Social Determinants of Health's very important report. And it concluded that inequalities in health and life expectancy all reflect social circumstances, and these are reflected in disparities both within and between countries. This diagram is a helpful way of understanding their proposal about how social determinants influence health. So we have, first of all, people's living circumstances, their own individual characteristics, and the psychological and social environments in which they live, but also their broader access to education, income-generating work, and the many factors that contribute to socioeconomic position. But I think our particular interest, and the part that has actually had least attention, is the part in the red box, which is the impact of the socio-economic and political context on the health of individuals and the communities in which they live. The Commission drew particular attention to the experiences of women and girls, and they concluded very strongly that women face particular challenges to their health because of discrimination, subordination and exploitation, and that these continue to contribute to the major burdens of disease that they carry. This report was launched more than 10 years ago, and one of the concerns, I think, worldwide is that it has still had so little impact. And I think we have an opportunity here to revisit this and think about the ways in which it still applies to our work now. And so that brings us to this very important strategy that has been launched, that we are going to have the opportunity to engage with and consider in detail, with its new focus on appreciation of the life course. Again, a further focus on the importance of consideration of prevention, of how we need to act early in order to enable people to live full and healthy lives, the importance of understanding gender-specific risks and the identification of the health effects of violence. And I will come back to that in a minute. We're all familiar with the notion of cultural competence. Many of us will have received training in cultural competence and how this pertains to our individual values and responses to diversity and to inclusion, and that it requires constant vigilance so that we don't become blind to the impact of diversity. But a construct is becoming of wider recognition is gender competence. And this is really the principles that we all need to adhere to and understand about how gender-based discriminatory attitudes and behaviours can influence our work. These require us to take explicit actions to counter gender-based stereotypes, whatever our field of endeavour, whether it's research or public policy or clinical practice. And we know that gender competence is associated with better health outcomes. Just to remind you of what stereotypes are, these are generalisations that are applied to particular groups that ignore diversity within groups, and most importantly, they're automatic or unconscious. These can be positive, almost invariably they are negative, and they can have very harmful repercussions. Gender-based stereotypes are those that pertain to characteristics and capabilities based on a person's sex, and they reinforce disparities in privileges and power, both in public and private spheres, and they can be used to blame victims. I want to turn to the illustrative examples I'd like to use from my own field of interest in mental health. And we know that there are significant gender-based risks to mental health, which is poor recognition of the burden of unpaid work, more limited access to financial decision-making, experiences of violence, not only those perpetrated by an intimate partner, but across the life course, and more difficult access to income-generating work. The disparity in mental health problems is illustrated by these three examples of prevalence estimates generated in different settings. In a private maternity hospital in Ballarat in Victoria, only 4% of women meet criteria for perinatal mental health problems, but a third of women in rural Vietnam and nearly 1 in 2 in the Swat Valley in Pakistan, a conflict-affected rural area in which many women are limited by gender-based traditional rules and about roles and responsibilities. And I think Vikram Patel, a very famous psychiatric epidemiologist's interpretation of these is incredibly important, that there is no biological factor that can explain these differences in outcomes, and that biological parameters do not show this degree of variability. We're obliged to look at the circumstances of people's lives. Gender-based stereotypes really are very common in the perinatal period, and they include how individual health professionals, but also public policies, consider roles and responsibilities for caregiving and about the distribution of household tasks and of presumptions about needs for health information and support. Some of you will be aware of work done here at the ANU which attempted to quantify the workload associated with caring for a 3-month-old baby. And they actually counted the number of feeds, episodes of soothing, episodes of bathing and interacting. And they estimated that this took about 160 of the 168 available hours in a particular week. And it took no account of what happened overnight, where there might be continued prolonged work. Australia has very clear rules about occupational health and safety for almost all workplaces, and these really describe how many hours it's safe for you to be at work, how many days you need to recover after a night shift, and how many hours of uninterrupted sleep you need between each shift. So we know that occupational fatigue really very much disrupts healthy functioning. It influences judgment and reaction time, concentration, capacity to learn and memory, and it also influences mood. But if you look at the research literature, this work is not named as work. Women are classified as not working, as being housewives, or only as working if they're working outside the home. And we have two very extensive evaluations that have sought to estimate the costs associated with mental health problems experienced by women at this phase of life, one by PwC and one by Deloitte, and they both conclude with these very detailed cost estimates that there is a huge impact on the economy if women have mental health problems that interfere with their caregiving capabilities. These are both open access and they do acknowledge some limitations, and we might say that they've perhaps drawn a rather long bow for some of their conclusions. But I know of no report that has estimated the value to Australia's economy of women's unpaid work. And this to me is such an exemplar of a devaluing of the work that women do predominantly in this community, even if they're also engaged in income-generating work. And if we think about how women are asked about this activity in clinical care, they're asked, when are you giving up work? They're asked, do you work? Are you going back to work? And the one I hate most, does he help you? With the implication that this is women's work with which men might occasionally assist. And these, to me, indicate significant and widespread gender stereotypes. And women have embodied this devaluing. They refer to themselves as not working. I'm just a, I'm only a, I'm a stay-at-home mother, as though this is somehow a less valuable contribution. It would make such a difference, in my opinion, and take no more time to ask women in gender-competent ways about their work. When are they starting work as a mother? What is your work, rather than do you work? How is work shared in your household? And that every opportunity is taken in these individual encounters to value women's contribution, about the amazing contribution they make through unpaid caregiving. And it might mean that we would then take their occupational fatigue a little more seriously. My next example is about the impact of intimate partner violence on mental health problems associated with childbearing. The first systematic review of this evidence was published in 2013, and it showed, just without any contest, that if you've experienced violence perpetrated by an intimate partner, you are 3 to 5 times more likely to experience a mental health problem during pregnancy or after giving birth. This systematic review concluded 67 studies. There was not a single study from Australia. We had no evidence yet to contribute to this, and that might have been addressed in the years since, but not very extensively. Mental health problems among women also intersect with other areas of disadvantage. Our recently published data about the mental health problems of women from conflict-affected backgrounds seeking antenatal care in Australian hospitals about half of whom in our conflict-affected group identified as refugees, showed that they had experienced multiple traumatising events and that intimate partner violence was a problem for them, but so were the other multiple forms of violence they'd experienced across their life course and during the transition. And refugees were much more likely than Australian women to be in economic stress and to lack social support. And they were, not surprisingly, much more likely to be experiencing mental health problems, and that being a refugee was one of the major risks. But there are no services for us to refer them to and little specific recognition of their needs. Australia is a signatory, as all member states are, to the Sustainable Development Agenda. It emphasises that gender empowerment and gender equity are fundamentally linked to health. We have an obligation as global citizens to ensure that our strategies adhere to what the Sustainable Development Agenda recommends and asks us all to contribute to and report on. And there is a specific strategy, a very helpful strategy, about the needs of women, children and adolescents in order to achieve good health. And what it emphasises is that we have to invest in research in order to build capacity, and that evidence needs to inform and underpin policy and practice. So we are being given a wonderful opportunity, an extraordinary opportunity to gather here shared interests and overlapping areas of expertise to really consider what women's health in 2019 towards 2030 actually demands of us. And I would encourage us all to bring with us very critical capacities for discernment about whether or not policy and the evidence for policy are yet adequately gender-informed. We all have to continue to be vigilant about our stereotypes and that these can be harmful to health. I hope never to be referred to again as a lady, let alone as a girl, and yet these are widespread experiences for women, and that health services need to be enhanced to provide not only person-centred care for all women, but care that is gender-informed. I look forward to working with you. Thank you.
Thank you, Jane, for those wonderful, clear reminders of important issues. I'd like now to invite Leanne Wells to join us. Leanne is the Chief Executive Officer of the Consumers Health Forum of Australia. She is a health advocate and service executive with over 30 years' experience. Throughout her career, she has worked in the health and social care sectors. She is a board director of Coordinaire South East New South Wales Primary Health Network, the AusHelp Foundation, Pain Australia, and Advancing Pharmacy Practice. Leanne, thank you.
What I thought I would speak about, I'm obviously not an expert in women's health, but there's been so much, a whole body of work put into developing the National Women's Health Strategy, the lead-up forums to today, and I understand today's focus and the course of the next day or so is on implementation and translation considerations. So I just wanted to make a couple of comments really about what I think is important in those implementation and translation conversations from I suppose, just a broader community, consumer, patient participation perspective that I think have, universal application. So just a little bit about Consumers Health Forum of Australia. That for those that don't know, we are the national peak body for Australian healthcare consumers and those with an interest in healthcare consumer affairs. So we are broad in membership. Jean Hales is one of our members and one of about 250 members of CHF. So patient-centred care, it's a pillar of Australia's healthcare system. To us and to everyone, all policymakers, all service providers, it should be a fundamental principle. But part of our challenge is that in many ways it does remain a principle, and the way we put it into practice is variable. I think most of you would agree with that comment. But the good thing is that we do have many levers at a policy level, at a system level, at a service level, to putting in place much more person and patient-centred approaches to care. Standard 2, for example, under the National Quality and Health Safety Service Standards, now being a mandatory standard, patients as partners in care, rather than what was previously called a developmental standard, is a good example. Primary health networks being required by their funders to have consumer and community engagement mechanisms that are meaningful and systemic, not tokenistic. But there's certainly been calls from consumers and from some of the big leading thinkers in health policy, the OECD, Health Ministerial Council, the Productivity Commission, the Grattan Institute and others, Rosemary's academic think tank, are all calling for and supporting the notion of patient-centred care as the way forward. And the Productivity Commission, the pointy end of town, if you like, went so far as saying in their recent 5-year Productivity Commission review, their Shifting the Dial report, that all Australian governments should reconfigure the health system around the principles of patient-centred care, and that be implemented in a 5-year framework. So that's our call to action, guys. Okay, so look, as CHF, we have welcomed and we've been involved in the development of the National Women's Health Strategy. We support the 5 priority areas that are identified in the strategy wholeheartedly, and some of the themes that seem to have come out quite strongly from our quick look at them from the forums in the lead up to this gathering range from social determinants of health, equity and equality, the importance of connectivity in the system for women and girls and the care that they should be getting, and building the health literacy of women and girls, particularly those most vulnerable, and then also the principle and the practice of co-design. So I'll come back and talk about some of those things in a minute. But I just like this comment from Karen Walker from the George Institute. I think it was written up in one of the reports from the forums, that we need to find better treatments, but we need to transform primary health care. And I think I'll talk a little bit about why we think primary health care is an important setting in a minute, and to harness the power of communities, governments and markets to improve women's health. We too value that comment. We think primary health care is important. And I think it's a busy horizon, that we've got at the moment. We've got the pinnacle of the National Women's Health Strategy, but we have a litany of other action plans and strategies, a child and youth action plan, 10-year action plan that's got elements of health and wellbeing for young female adolescents. We have post-election commitments from Minister Hunt to the development of a 10-year primary healthcare strategy and a 10-year prevention strategy. They're plans with enormous potential. I think our challenge, all of us, is how, with those strategies on the horizon, do we engage and ensure that women's health and some of those particular women's health and gender issues are intrinsic and really thought about in the context of those strategies, as well as the implementation of the National Women's Health Strategy. So I think it's incumbent on all of us as stakeholders and experts to really get in and actively shape what we would like to think will be aspirational primary health and prevention plans. I know it probably feels like a Groundhog Day for most of us, but it is an opportunity. And it'll be crucial to implementation that occurs with a wide range of stakeholders. So I just wanted to make a few comments about primary health care and that setting and its relevance for women and children in particular, and why we think integrated primary health care matters to consumers in the community. I mean, its key principle is person-centred care, and really what we're looking for with an integrated primary health care set of arrangements, both at the policy level and the service level, is a knitting together, I suppose, and better connectedness between service settings, primary care, acute care and social care. We need an open and connected system because at the primary care level, because after all, care is much more than hospitals, and that's a whole interesting debate in itself about where acute and hospital care is going to go into the future. But what people are really commanding, certainly in our research, in the literature, in what the literature tells us about best practice primary health care and how it should be better organised and best organised, are those principles there on the slide. I won't read them, they're familiar to you all, but I think one of the critical things that we think is important to bringing that about are new models of care. We are very strong proponents of the notion of a patient and family-centred healthcare home type model of care at CHF. We've had some little experiments or forays into those sorts of models, the healthcare home program, and a voluntary enrolment initiative that'll enrol people over 70s into a different way of funding general practice. But we also are very strong proponents that if we want a person and family and communities of interest set of arrangements that determine how healthcare is planned and delivered, in a country with our diversity, in a country with our communities of interest, we do need place-based approaches. We need governments, federal, state, regional, to work together, to talk to each other. We need national funding, dare I say it, pooled with state funding. We need regional commissioning, regional co-commissioning, and local service delivery that really assures that precious health money is really targeting need and in a way that has very public and visible responsibility and accountability for outcomes. So what I'm really saying there in a nutshell is that CHF is a big proponent of place-based approaches to organising care, because all the evidence tells us that if you want integrated services, the closer they can be designed and delivered to the point of care delivery, the better result we get. So, subsidiarity, to use the jargon word. Okay, another key theme that struck us as emerging throughout the recent Women's Health Forums was the health literacy of women and girls. Health literacy, we believe, is a cornerstone of providing patient-centred care. It's the wherewithal, it's knowing how to navigate the system, it's knowing what it is about your condition, how do you self-manage, where can you go to access services, those really practical things. So it influences health, it influences well-being, it influences safety and quality of care, and it is a determinant of the utilisation of healthcare services. Fundamental to practical shared decision-making between a team of clinicians and a patient. So it's widely reported through the literature that low levels of health literacy skills are associated with poorer overall health status and outcomes, decreased capacity to manage chronic diseases, higher rates of hospitalisation and emergency care use, and increased patient costs. Patient activation or self-management also has to be in the mix. And this is about patient knowledge, skill and confidence to take on the role of managing health and healthcare, exercising choice and control. This is particularly important for people with chronic conditions, particularly important for people who are high users of the healthcare system. Women in particular falling into that category in many senses. And it's also important because we're reminded that particularly for people with chronic conditions, they spend less than 1% of their time in contact with health professionals, meaning that up to 99% of their time they're self-managing or they're managing with the support of a carer. So gearing our system around the benefit of supporting or better supporting patient self-management makes economic sense. A recent UK Health Foundation report showed that patients most able to manage their health conditions had 38% fewer emergency department admissions, 32% fewer emergency department attendances, and 18% fewer GP appointments than those who are less able. We've just completed a national survey using the validated patient activation measure tool to have a look at, and we surveyed 1,800 people with 2 or more chronic conditions, just to have a look at what their levels of patient activation were, how they segment using that patient activation measure, what their health literacy levels were, and what that looked like when it was cross-referenced to their health service utilisation patterns. So that report will be released tomorrow. We haven't done specific unpacking of the data yet around responses from women, but we do plan to do that as a next stage drill down. But it's just interesting there, you can see on that slide that there are 4 levels of activation, starting with level 1, where a patient is really only being activated to start to take an active role in managing their care, relatively low levels of health literacy, lacking in confidence to navigate the system, right up to people that, according to that activation measure, are very competent and confident in maintaining their health behaviours, in managing their health, accessing the services they need. And so this is a top-line result here that only 1/4 of those respondents, so we're talking 1,800 people with 2 or more chronic conditions, were classified as level 4, meaning they've adopted behaviours to support their health well, with a further 41% of respondents classified as level 3. They're starting to act in a self-managing way, but lacking skill and confidence. So we've got a lot of work to do. I think one of the take-out messages I really wanted to reinforce today is that one of the things that we're advocating for and looking at ways for the system to better support consumer participation and involvement in care, whether it's at the point of care shared decision-making level or sitting at the policy table, is to challenge the notion that consumers are representatives, that they are passive participants. We think we really need to change the lexicon and change the practice so that we are thinking of consumers as leaders and specialist advisors and supporting them with leadership development opportunities to fulfil those different leadership roles. And they fulfil those roles in all sorts of ways as participants and co-shapers of research, for example, and helping to translate and take meaning out of research findings, helping to determine policy, working with PHNs to redesign or recommission or decommission services. Okay. So one of the things we're doing is a national demonstration of a program called Collaborative Pairs, where we're actually giving that a crack. We're working with consumers and clinicians who form a pair and do a leadership training course together on a shared work challenge. We've just finished the national evaluation of that, and we think that is showing promise. It's not the only model, but it's certainly a promising model, and we're looking forward to working with government to look at how we can scale that up. So, look, key takeaways: implementation matters. It's one thing to have strategies. We've had a litany of women's health strategies over the course of the last 15 years. We've got several strategies in development and action plans in development. Lots of goodwill across all of those, but implementation matters. Implementation shouldn't be an afterthought, requires planning, and it does need to continue to involve the perspective, in this case, of this strategy of women and girls and young women in its implementation and in priority setting. We really do need to harness and act on the knowledge and expertise of consumers. They are system assets and enablers. They are agents of change. And the ideal approach, last point, is co-design, to take a co-design approach to policy, program, services, and a shared decision-making approach at the point of care delivery. Thank you.
So our final speaker is Dr. Vijay Roach. Vijay is a specialist obstetrician and gynaecologist with 25 years of experience in both public and private practice in Sydney. He's the president of the Royal Australian and New Zealand College of Obstetricians and Gynaecologists and the former chairman of the Gidget Foundation, a role in which he passionately advocated for those affected by mental health disorders in pregnancy and early parenting. Thank you very much.
I want to start off by acknowledging country as well. I want to recognise something that I've learnt in this role, which has been that we can say that we acknowledge the local people, we can thank them for welcoming us onto their land. But one of the opportunities that I've had has been to, recently was the Australian Indigenous Doctors Association meeting in Darwin. And then I realised that I actually didn't know anything at all. That there I was, this self-righteous lefty who thought that he understood what the issues were for Aboriginal and Torres Strait Islander people and understood what they felt and what culture was and all that sort of thing. And then I realised that the depth, that while I might be able to think back a generation or two or three or four, these are people who think back 60,000 years and they feel it. And they feel it in themselves, and it informs everything that they do and everything that they experience, and that this was their land, that they still belong to it. And so to be welcomed onto their land, I think, is an enormous privilege, and for us to acknowledge it, I think, is extremely important. And then that moves into something that Jane said, which was talking about the importance of the social determinants of health. And I think that that's something that we're increasingly realising, that you don't just look at health in a biological context. But one of the things that was said in a very elegant presentation that was given at that conference was on the cultural determinants of health as well. And I think that that word expands the concept of social determinants of health, is that if we understand that cultural determinants of health actually can affect someone intergenerationally, that it comes through, and we have biological plausibility to back that up as well, but realising that we need to understand a person in the context of their culture, not just necessarily their economic or current social circumstances. I'd like to acknowledge David and Rachel, who are the two people who I have met through the Jean Hales Foundation. And the reason that I want to acknowledge them, I think, is relevant to everybody who's in this room. Because too often when we work in this space, we work as researchers, as academics, as clinicians, as policymakers, and as Leanne talked about, consumers, but we work in an isolated manner. We work in a siloed manner and we don't talk to each other, and we go off and we do our own project and we don't communicate what we're doing with each other. And David and Rachel, I think, have changed that landscape and changed it really quite dramatically, because they brought all of us together, and they brought us together in a spirit of collaboration. And I think that that's something that we should really all acknowledge. So thank you. I could spend my whole talk talking about Jane Fisher, but I won't. When Kathy, my wife, knew that I was coming to Canberra, the only thing that she was jealous about was the fact that I was going to see Jane. But no, Jane is our hero. Leanne, thank you for setting that scene and for putting the consumer into the picture. And I thought that I would talk a little bit, give a sort of case example to give my understanding of the importance of the consumer. I remember actually in the distant past being involved in a New South Wales maternity health document, and we spent hours and hours and went over, debated every single dot point, and we had the best strategy for maternal health in the country. And then at the last meeting, just when it's about to go to the press, I said, look, there's only one thing I'd like to point out, which is that this magnificent document doesn't mention a mother or a baby. And I think that says it all. And I really would, a nice little job for a PhD student would be to go through every maternity document and find out how often mothers and babies are actually mentioned in it. But I also realised that as a healthcare provider, as an obstetrician and gynaecologist, I never got it. I really didn't get it. We are the people who are educated. We're the people with the knowledge and the science, and that's why people come to us, and it's our job to tell them what to do. Now, and then there was a 32-year-old woman who had an unplanned pregnancy, successful in her work, successful in her personal life, and but unplanned, shocked by it, but then embracing it and wanting to do it, and wanting to do pregnancy and birth in the way that she wanted to do it. Her blood pressure went up, So the doctors came in and they said, you need to be on medication and you need to be hospitalised and you need to give up work because all of this is for your good and for your baby. And now you can't have your baby in the birth centre in the way that you wanted to. You need to go to a labour ward and you need to be induced. And now because the pain's so unbearable, you need to have an epidural. And by the way, when you eventually have that awful forceps delivery, and then you must breastfeed because this is what we believe is best for you, not what do you want. And what happened to that woman, that successful, extraordinarily amazing woman, was that after that, she fell apart. But did we ask her how she was? Did we say, how was that experience? No. We just thought that it all looked pretty on the outside. So for 2 years, that woman, who then had another unplanned pregnancy, would take her 2 little boys in the morning and she would put them in a cot. And then she would go and sit on the kitchen floor and she would rock herself having suicidal thoughts. And nobody knew what was happening. Until by chance someone made a diagnosis, she was admitted to a psychiatric hospital for 6 weeks, she was put on medication, and she and her partner struggled for 5 years and eventually came back. That consumer then went on to become the CEO of the Gidget Foundation, an organisation that raised awareness about anxiety and depression in association with pregnancy. She had no medical background, no medical knowledge, but she taught herself the psychology, she taught herself the psychiatry, she taught herself the medicine, she taught herself how to run a not-for-profit organisation, and she changed the landscape of that disease in this country unlike any other person. And her husband, who's a doctor, didn't get it, couldn't believe that someone who didn't have medical education would be able to achieve those things. He thought that a consumer couldn't make that contribution, and he was very wrong. And the reason that I tell you that story is to make it real, because that's the message that I want to give today, is to make this real, because that woman was my wife, and that husband was me, and that was a journey that I went on. And I think that if we're going to have this conversation, I think that it's critical that we start to make the personal political. What we need to ask ourselves over the next couple of days is why? Why are we doing what we're doing? And Jane posed that question. Because too often we concentrate on the what and the how. What's the problem? What do we need to do? How are we going to do it? But to understand why, I think we need to go right back to the beginning. And the beginning was when Eve gave Adam that apple. And Eve brought about the downfall of man, and they were banished from the Garden of Eden, and henceforth women would bear children in pain. And the religious people said they actually did not allow women to receive pain relief. It was illegal. It was considered immoral. And it was only when Queen Victoria was given chloroform during her labours that things started to change. But I think the thing is that the attitude towards women continues today. And so everything that we heard there, we need to know what underpins that. And we think that that happens in other countries. We think it happens in other cultures. Well, it doesn't. We just do it in a more sophisticated way. And so we mustn't do that finding easy scapegoats overseas or in other cultures about the subjugation of women. It behoves us to turn the lens on ourselves, because in Australia we fail to value women. In Australia, women are second-class citizens economically, socially, and in healthcare. In reproductive health, women are denied access to safe abortion. Abortion has only now, after 119 years, been decriminalised in New South Wales. And if you listen to the media reports, if you listen to the talkback radio, if you listen to the politicians talking about women, it was so distressing. A woman does not have the right to control her own body. And when I listened to that debate, I developed a vision, an image in my head, which is of a woman sitting there, naked, publicly exposed, and we were talking about her. My wife and I have 5 children. And my deepest regret, when I reflect back on our reproductive story, but her reproductive story, was that when she found out that she was pregnant in an unplanned way, I haven't been asked to talk about contraception, when she found out that she was pregnant in an unplanned way, nobody asked her what she wanted. I don't know what choice she would have made because I never asked her what she wanted. Her role on the planet was to be pregnant and to have children. And so therefore, once she was pregnant, that was the end of the discussion. Whatever impact it was going to have on her was not important. I don't think that healthcare is about policy. It's about people. It's not about healthcare providers. It's about consumers. It's about those who are affected. My hope is that what we're going to discuss over the next 2 days is the people who are affected and those who matter. And those people are our mothers, they're our sisters, they're our daughters, they're our colleagues, they're our friends. They're ourselves. They're not some abstract concept. Women are people too. And we, as healthcare providers in particular, we need to learn to listen. There's that classic statistic that the average doctor will interrupt their patient within 18 seconds of the consultation beginning. And I thought, oh, that couldn't possibly be me because I'm so kind and caring and understanding. And a woman comes in and she starts talking about her menstrual history and I think, bang, I know exactly what... And then I realised I hadn't actually heard her story. So I actually now physically put my pen down and sit on my hands so that I hear that story, because if you listen, people will tell you everything that you need to know. We need to start with the premise that women are people too, because if we do, then every aspect of the way we approach this conversation will be real. We will make the person political. So finally, and the timekeepers will like the word finally, and most of the audience will always... People always sit up because they think, oh, beauty, now we're coming to the end. I think that what we need to do in this room is we also have another responsibility. It's not good enough to simply research, write papers, give presentations, produce pamphlets, formulate all sorts of programs, go and talk to politicians. I'm actually challenging you with a bigger responsibility than that. We are leaders and we need to walk the walk. We need to be loud and vocal advocates. One of the conversations that I had during the abortion law process was with the Greens. And in one in particular, Abigail Boyd, who was a passionate and eloquent advocate for women. And she pointed out the irony that when the Greens talk about climate change, or they talk about economic reform, or they talk about the rights of women, or humane treatment of animals, or cleaner forms of energy, then they're painted as radicals. What a radical concept that is. Those who want a better world are apparently radical. Well, my call to all of you is to be radicals. I want you to be extremists. I want you to be loud and angry feminists, because the status of women's health is simply not good enough. It's unacceptable. It has to change. That has to be our premise for this strategy. I think we need to say it very, very loudly. It's not about equality, it's about equity. It's about women having access to health, women having opportunities to lead happy and productive lives, women living without fear of violence or harassment, women having power and being empowered. We don't need to help women. You know, I love this quote. Feminism isn't about making women strong. Women are already strong. It's about changing the way that the world perceives that strength. And I want to also point out another very important thing, that amongst feminists, I include myself. I'm standing here as a person, as a partner, as a parent, and as a child. I'm not a male champion for change or a knight in shining armour. I'm a person, and I want to stand alongside other people. And when women have the same opportunities as men, then gender will no longer matter, and I won't be characterised by my gender, because I will have an equal partner in the things that matter. So I want to finish by saying that the task before us is monumental. Actually, it's too much. It can't be achieved. We're all overwhelmed. We've had this conversation before. But I think that I want you to remember that what we're talking about is every woman, your sister, your daughter, your mother, your friend. And so I want to leave you with an image, that you're walking along a beach and you see an old man walking along that same beach, and he's tired and he's grumpy and he's cynical and he's given up. But there's been a great storm and the beach is covered with starfish. And the old man comes across a little boy and he's picking up the starfish and trying to return them to the water. And the old man comes up and says, "This is ridiculous. The problem is overwhelming. There is nothing that can be done here. You're not going to make a difference. And the little boy bends down and he picks up a starfish and he places it in the water and he says, well, I think that it made a difference to that one. So I too am overwhelmed by the task ahead of us, but I think that we should believe in ourselves. We should believe in this collaborative relationship that we've got. We should recognise the value of what we are doing. This is it. This is it. This is what matters. This is what will change society. This is what will change history. This is what will be the thing that we want generations to look back and say that this was a turning point in which we finally realised that we are a community of people and that women matter, and because they matter, then we have made the changes that will enable them to have their place in this world. But let's make it personal, because then it always underpins what we do, because if we change the story for one person, then I believe that together we will change the world. Thank you.